Welcome to this session in which we're going to continue our look at systematic reviews and critical appraisal.
What is the difference between a traditional or narrative and a systematic review? It is common to confuse systematic and literature reviews, as both are used to provide a summary of the existing literature or research on a specific topic. Even with this common ground, however, both types vary significantly. In broad terms, a systematic review is a high-level overview of primary research on a focused question that identifies, selects, synthesizes, and appraises high-quality research evidence relevant to that question. A narrative or a traditional review qualitatively summarizes evidence on a topic, using informal or subjective methods to collect and interpret studies. In this slide, we look at the differences in a little more detail. We can see here the definition, what we talked about in the previous slide. It's a high-level overview of primary research. Its goal is to answer a focused clinical question, and another goal is to eliminate bias. The question will try to answer a clearly defined clinical question, and it will probably use the PICO guidelines that we discussed elsewhere. The components of a systematic review are pre-specified eligibility criteria, a systematic search strategy, assessment of the validity of findings, interpretation and presentation of results. The literature review, on the other hand, qualitatively summarizes evidence on a topic using more informal methods, and its goal is to provide a summary of or an overview of a topic. And it can be a general topic or a more specific question.
As this slide shows, studies indicate that clinical questions arise very frequently in clinical practice, and asking a focused clinical question is the first step in getting an evidence-based answer quickly. So, for example, one of your long-time patients with chronic osteoarthritis of the knee brings in a bottle of glucosamine tablets. She has been buying them for the last few months and asks if it would be helpful for her to keep taking them. You wonder the same thing. Other questions pop into your mind. How do these substances work? Are they better than NSAIDs that she's been taking? In the evidence-based medicine process, a physician asks a clinical question, searches the medical literature, evaluates the answer found, and applies the information to the patient. Although the evidence-based medicine process can seem cumbersome, there have been several advances that make it much simpler. Firstly, the internet has improved access to journal articles and other medical references and has sped up the searching process. In addition, we now know what kinds of evidence provide most value. For questions of therapy, most experts agree that randomized controlled trials, preferably analyzed together in a meta-analysis, provide the strongest data. Studies of patient-oriented outcomes such as mortality, morbidity, and quality of life are the most relevant for patients. Background questions generally ask who, what, when, where, or how questions about a single disease or drug. For example, in the case of the patient taking glucosamine, we might ask background questions such as these. What are the side effects of taking this medicine? Or how does glucosamine work to treat osteoarthritis? As doctors and health professionals gain experience, they master the background knowledge they need and shift towards asking more complex questions. So as we've just mentioned, background questions generally ask who, what, when, where, or how questions about a single disease. Foreground questions always compare two things: two drugs or treatment, the prognosis of two groups, two diagnostic tests, or the harms or benefits of two approaches. To format foreground questions clearly, we should use the PICO format, which stands for patient, intervention, comparison, and outcome. Since background questions ask for general knowledge of disease process or clinical circumstances, textbooks and review articles are the quickest place to find direct and reliable answers. You may need to use a database such as Medline to find an appropriate review article. Foreground questions can be more difficult to answer than background questions because they require a source that synthesizes a wide range of knowledge. PubMed is an easy and free place to search for answers to foreground questions, and it offers links to a growing number of free full-text articles. In constructing more complex searches, use the PICO format can help you to identify your search terms. Start by combining your most significant patient characteristics, the P in PICO, with the intervention. If you get too many results from the search or don't find your answer, then add the comparison intervention to your lists. For example, to find studies that compare the efficacy of glucosamine versus NSAIDs for osteoarthritis, your initial search terms could be osteoarthritis and glucosamine. If that search didn't retrieve articles that answer the question, the next search should be osteoarthritis and glucosamine and NSAIDs.
In order to find the results relevant to your topic, you should first of all check your spelling. Most search engines can't interpret your typos or spelling mistakes. If the material is published outside of the United States, consider alternative spellings. Second, using more search terms yields fewer results, which may be a problem in a small database. For example, a search for osteoarthritis will yield broader results than searching for osteoarthritis prognosis in women over the age of 65. Third, consider using quotation marks around phrases. For example, exercise-induced asthma tells the search engine to find all of these words in a row exactly as you type them, rather than looking for these words separately in the document. And finally, use capitalized "and" to combine search terms. Most search engines interpret the capitalized words "and" as a command to find only pages that mention both terms that it joins.
We'll just have a quick look at search tips for efficient results. So use search limits to get more relevant articles. For example, publication date and language are two of the most efficient limits in PubMed. You may want to limit your search to more recent literature, for example. PubMed also indexes articles from more than 70 countries, so limiting results to one or two languages will also reduce the number of irrelevant citations. We'll just have a look at the search strategy from one paper. This is the paper here. It's called Topical NSAIDs for Chronic Musculoskeletal Pain in Adults, and it was published in the Cochrane Database of Systematic Reviews in 2012. And this shows some of the terms that were used in the search strategy. The article states that a series of electronic searches together with bibliographic searches and searches of in-house databases were combined with electronic searches of clinical trial registers and manufacturers of topical NSAIDs, or companies known to be actively researching topical NSAIDs. There had to be at least 10 participants in each treatment arm with application of treatment at least once daily. Search methods for identification of studies. There was electronic searches, and they list the various databases with the time periods that there was used. They state that there was no language restrictions. They also looked at other resources. They searched reference lists of review articles and included studies and in-house databases of older studies. Manufacturers had previously been asked for details of unpublished studies, and for this review they asked companies with research interests or products licensed for chronic musculoskeletal pains about unpublished studies. One company provided information on published and unpublished trials. In terms of the selection of studies, 2 authors read the abstract of each study identified by the search, eliminated studies that clearly did not satisfy the inclusion criteria, and obtained full copies of the remaining studies. The same authors then independently read these studies to determine eligibility. Any uncertainty or disagreements were settled by discussion with a third review author if necessary.
Whatever type of review you do, a useful tool for systematic searching is MESH, which stands for the Medical Subject Headings. The MESH browser is an online vocabulary lookup aid available for use with MESH. MESH Subject Headings is a National Library of Medicine controlled vocabulary thesaurus used for indexing articles for PubMed. This slide shows an example of MESH indexing for a specific article. Here we can see the title of the article and the abstract of the article. And here we can see the MESH terms that are used to index the article. So as we've said, the MESH controlled vocabulary is a distinctive feature of Medline. It imposes uniformity and consistency to the index of biomedical literature. MESH terms are arranged in a hierarchy called MESH tree structures and are updated annually. The MESH terms are labels assigned to each article in Medline to describe the article. And the National Library of Medicine uses indexers that look at each article and assign 10 to 12 labels which best describe the content of the article. MESH terms are organised into a hierarchy called the MESH tree, and here we can see an example using the phrase congenital abnormalities, and we can see branches further down the tree here. Another example might be diabetes mellitus. You would see that there are several types of this disorder, such as type 1, type 2 and gestational, listed in the tree as branches of diabetes mellitus. If you choose to explode your MESH terms, all the subtypes will be included in the search as well. MESH provides two tools to help authors select MESH descriptors as keywords for articles. First, we have MESH on Demand. This tool can automatically identify relevant MESH terms from text such as an abstract. It uses natural language processing and the NLM Medical Text Indexer to find MESH terms. Secondly, we have the MESH browser. This tool allows users to search directly for MESH terms. Here we see an example of MESH on Demand using the natural language word addiction. First, we see that the actual MESH term is behaviour, addiction, and possibly another term that might be relevant is substance-related disorders. It also shows a list of papers that may be relevant to help you with your search. Another feature of the browser is that you can choose between an exact match or a fragment. Exact match finds terms that precisely match your search term regardless of whether the term has upper and lower case characters. All fragments finds terms that includes all fragments of a search string in any particular order, while any fragment finds terms that include at least one fragment of a search string. As we have discussed, MESH is one example of a controlled vocabulary. It can be used while searching the Medline database via PubMed. It's created and maintained by the National Library of Medicine. Subject headings are applied to every article indexed in PubMed to identify key topics of the publication. The MESH database allows you to search for the control terms using keywords and to build a search to use in PubMed.
I'd like to look at one systematic review which was part of research published in this paper here, called The Relative Importance of Perceived Doctors' Attitudes on the Decision to Consult for Systematic Osteoarthritis, a choice-based conjoint analysis study. Conjoint analysis is a technique used in market research that helps to determine how people value different attributes, the features, the functions, the benefits of something that make up an individual product or service, and it's something that's increasingly being used in health services research. The object of conjoint analysis is to determine what combination of a limited number of attributes is most influential in making a decision. So the overall aim of the systematic review is to identify previous health applications of conjoint analysis techniques and to critically evaluate the suitability of these methods in terms of feasibility and validity for use in future experiments involving older adults and the decision to consult in general practice. So the systematic review led to a new study with a new set of attributes based on the review. Here we can see the attributes and the importance of those attributes as they emerged from the new study. So the most important determinants of the patient's decision to consult the GP for joint pain were the extent to which pain disrupted everyday life and perceived GP's attitude. Thoroughness of assessment, management options, comorbidity and pain characteristics were less strongly associated with consultation. So the conclusions of the study were that anticipating that the GP will regard joint pain as part of the normal aging process is a strong disincentive to seeking help, potentially outweighing other aspects of quality of care. An important goal of primary care consultation for osteoarthritis should be to avoid imparting or reinforcing this perception. Before we look at the results of the systematic review, we'll just have a quick look at conjoint analysis. So, as we said, we're looking at how people make a decision to consult for systematic osteoarthritis. And in the actual study that we conducted, we looked at 6 characteristics. There were different levels associated with each characteristic. So, for example, with regard to pain, it could be you're experiencing a dull pain, which is there most of the time, or you're experiencing short episodes of more severe, often unpredictable pain. So you can see for each of these attributes and the levels, you might decide to consult or not consult a GP. And what we wanted to know is which combination of characteristics are the ones that will lead to consulting or not consulting. And this is very similar to the way that we make decisions about lots of products and services. Though we don't have to go into too much detail, essentially what we do, we presented people with a series of scenarios involving combinations of these attributes and levels, and then people had to choose between one or other. So that was the actual task and the results that are reported in the paper that I mentioned. So what we did was we took the question and we expressed it using the PICO format. So first of all, we look at the P aspect of the PICO participants. So we looked at studies focused on primary care users and any health condition. The intervention was conjoint analysis, and there are a number of terms that can be used when using conjoint analysis, and so these were the ones that we looked at. There's no real comparison in this situation. We're not comparing one thing against another, so that's not really relevant. And the outcome of interest was preferences for primary care consultations with emphasis on patient-centered care attributes such as assessment by the GP, management in primary care, and also GP attitudes. So that's how we expressed the question using the PICO format. So using the PICO format and turning it into a search strategy, these are the results of the study. So a total of 1,267 citations were identified from these different databases that you can see. Duplicates were excluded, 1,000 abstracts were read, a further 1,077 studies were excluded based on the exclusion criteria. The main reasons for exclusion were that studies did not use conjoint analysis, did not focus on patient-centered care, and they weren't in the context of GP primary care consultation. If the studies were primarily empirical studies, such as methodological reviews, these were also excluded. And here we see the results expressed using the Prisma flow diagram that we've talked about earlier. So we start off with 1,267 records, and you can see that various cases were removed for a variety of reasons. Duplicates, didn't use conjoint analysis, didn't have patient-focused outcomes, etc. And so what we were left with was 15 papers that were included in a qualitative synthesis and no papers that were included in a quantitative synthesis. And we'll look at the characteristics of this qualitative synthesis.
The thesis used a checklist to describe the different studies. Note that this checklist is specific to conjoint analysis studies. There are 10 questions with 3 sub-questions. This slide shows questions 1 to 4. For example, question 4 is, was the choice of experimental design justified and evaluated? And you can see that there are more details for this question here.
And here we see some more of the questions. For example, question 5.1, was there significant motivation and explanation of conjoint tasks? Quite complex questions. Was the data collection instrument designed appropriately? So these are not necessarily points that everybody is going to agree on, as we will see later. Were the attributes and levels defined, and was any contextual information provided? So as I've said, a close reading of the paper is required in order to be able to address all these questions. A number of methodologies have been developed for looking at the quality of papers used in systematic reviews. And in the case of conjoint analysis, there is a specific methodology which consists of 10 questions with a series of sub-questions. This slide shows some of the questions. So for example, 1.1, were a well-defined research question and testable hypothesis articulated? 1.2, was the study perspective described, and was the study placed in a particular decision-making or policy context? So these all require reading the paper quite closely. We then come to more methodological points like, was the construction of tasks appropriate? Was the number of attributes in each conjoint task justified? So these are quite detailed questions that have to be addressed by whoever is reviewing the paper. So the 30 ISPOR items were applied to 15 studies, and 2 reviewers looked at these 15 studies. So there's a total of 450 data points, 30 ISPOR times 15 studies. And we can see that reviewer A and reviewer B answered yes to 271 items and no to 33 items, and there was different combinations for the other items. And from this we can calculate a degree of agreement between the 2 studies. This is called the kappa coefficient seen here. So kappa has a maximum of 1 when agreement is perfect. 0 indicates no agreement, better than chance. It can therefore be seen that in this study there was fair agreement, as shown by this table here. So as you can see, it's not easy when you're reading papers to necessarily agree on an interpretation. So item 1 in the ISPOR checklist was there a well-defined research question stated, and is conjoint an appropriate method? And for that there was a very high degree of agreement, 82%. Item 4, was the choice of experimental design justified and evaluated? Had the lowest agreement at 49%. So as I've said, it's there's a lot of interpretation involved in assessing papers. So we then move on to extracting information from the papers. And here we can see the information that the reviewers extracted from the paper: the year of the study, the setting, type of study, objects of the study, type of experimental design, attributes, and main findings. Here we can see a sample of some of the data that were extracted from the studies. Just looking at two of the studies, there was 15 in total conducted in primary care settings. 11 were based in the UK, 2 in Australia, 1 in Sweden, and 1 in the USA. Sample sizes ranged from 51 to 3,893, and response rates ranged from 18% to 94%. And we can see the type of information, how the sampling was done, the age characteristics, how many levels and attributes there were, just some indication of the main finding. There's more detail later on, and the type of statistical analysis. This table is just really to provide background information for the reader before proceeding to more detailed analysis. The next level involves interpretation of the study's findings. This involves going through each study and looking at the attributes. For each of the 15 reviewed studies, the attributes were ranked in order of their relative importance within the individual study. For example, in the Cherigai-Sohi et al. Study in 2008, the patient-centered care questionnaire found that the most important attributes was physicians' knowledge of the patient. Then we have the other studies looking at the most important attribute. So, for example, the Rubin et al. Study was being able to choose the doctor. Was the doctor trustworthy in this study? The patient's interview over the care received, large influenced, etc. So here we can see what attribute is the most important, and what level of the attribute was the most important. And this slide carries on the process, this time looking at interpersonal and technical care attributes. So, for example, the doctor listens as an important attribute compared to the two levels of the attribute. The doctor does not seem to listen and doctor does seem to listen. The doctor's manner, etc. And again, we can see which attributes and levels are important. And we see the other attribute here which are the process attributes, waiting time between making a non-urgent appointment. So here we can see how in each study the attributes and the levels have merged from the conjoint analysis process.
These attributes were then used to inform a new study. 863 people responded. The most important determinant of patients' decision to consult the GP for joint pain were the extent to which pain disrupted everyday life. As we can see here on the slide, 31%. And perceived GP attitude, i.e. legitimate problem requiring treatment versus part of the normal aging process. And you can see the other attributes here. Thoroughness of assessment, management options offered, comorbidity and pain characteristics were less strongly associated with the decision to consult. The conclusion of this study was that anticipating that the GP will regard joint pain as part of the normal aging process that one just has to accept is a strong disincentive to seeking help, potentially outweighing other aspects of quality of care. An important goal of each primary care consultation for osteoarthritis should be to avoid imparting or reinforcing this perception.
In the previous example, we looked at a systematic review, but the synthesis of the papers was in form of a narrative rather than a quantitative analysis. This time we're going to look at a quantitative analysis, and the results of this are included in a meta-analysis. So we're going to look at the efficacy, a paper that looks at the efficacy and safety of exogenous melatonin for primary sleep disorders, published in 2005. And the key variable that we're going to look at is sleep onset latency. That is the amount of time it takes you to go from being fully awake to being asleep. And we'll just look at one aspect of it. So the combined results of the 14 trials included showed that those in the melatonin group had shorter sleep onset latency than those in the placebo group. And the combined difference was nearly 12 minutes, with a confidence interval of somewhere between 5 minutes and 18 minutes. So in the samples of study used, it was around 12 minutes, but in the actual population, it could be somewhere between 5 and 18 minutes. And the authors interpret this as follows. They say, although the results were statistically significant, the effect appears to be clinically unimportant. So we're not going to look at the aspects of it here. We're just going to look at the data from the study. Here we see a forest plot of sleep onset latency in people with a primary sleep disorder. And down here we can see if it's to the left of the line, then it favors melatonin, meaning that there's getting to sleep quicker. And here we see favors placebo. And we can see that for most of the studies, there's a small difference towards suggesting that melatonin does help to get to sleep slightly more quickly, although some of the points lie on the line and one lies to the right favoring placebo. But when we put all these together, you can see that it comes up with an average figure of nearly 12 minutes. So people who take melatonin get to sleep 12 minutes earlier. But we see that there's a lot of heterogeneity in the study. What does this mean? So there's many things that can contribute towards heterogeneity: the age of the subjects, the dosage, the timing of the drug, the study duration, the diagnosis that people receive, the study design, and the quality of the study. So all of these are factored into this test for heterogeneity, and it comes up with a high score. So what the authors conclude is that although the result was statistically significant, the effect appears to be clinically unimportant. So this is something that we sometimes see in studies where something can be statistically significant, but for various reasons, the authors interpret it to be not clinically significant. So there again, it just illustrates the complexity of both conducting and interpreting a systematic review, in this case, a meta-analysis.
In this table, we look at the different factors that might affect the results. Heterogeneity is used to describe important differences in studies included in a meta-analysis that may make it inappropriate to combine the studies. Heterogeneity may be clinical, e.g. important differences between study participants, baseline disease severity and interventions. It could be methodological, important differences in the design and conduct of the study, or statistical, e.g. important differences in the quantitative results or reported effects. If we look at one example in this table of the factor age, we can see the subgroups explored are children, adults and the elderly, and we can see the number of studies reported, and we can see the point estimate, and we can see that the point estimate for children is larger than for adults and elderly. For children there is negligible heterogeneity, whereas for adults and the elderly there is more heterogeneity.
Let's have a review question. Which of the following describes a meta-analysis? Is it A, analysis of very large studies, B, analysis of the method of statistical analysis, C, establishing external validity, or D, detecting trends across studies that may have used different procedures, number of participants, type of control procedures, and different forms of measurement? The question was, which of the following describes a meta-analysis? And the answer is D. something that detects trends across studies that may have used different procedures, etc. So a meta-analysis is a statistically acceptable way of assessing the strength of particular findings across a number of different studies. And finally, here are some references for further reading on this topic.